Well, I certainly want to start off my own thanks to the CCF and the team here for inviting me to talk today a little bit, just about 15 minutes, about where we're going in pediatric brain tumor treatment paradigms. But first, I wanted to extend my thanks that we are all sitting here today and we are not in yet another Zoom meeting. I don't know how many more of those I can do. And just talking to the group this morning, I think that many of us are finding our legs getting back in person, putting our clothes on correctly. And I kid you not, last week I was interviewing for a position at Children's National, and the interviewee actually told me, and at that point I guess it was in confidence, but that she was actually wearing pajama bottoms. So I'm grateful. I'm going to check and make sure that I don't have pajama bottoms on. No, I have a full suit on. But with no further ado, we'll launch into what we're talking about today. So it's hard to know where we're going with pediatric clinical care in the brain tumor community without knowing where we've been. So I'll talk just a little bit about our most recent advances in our clinical trial infrastructure and landscape. And then it's really difficult to talk about how we're changing the way we're treating children with brain tumors without talking a little bit about the major biological breakthroughs that have happened over the last decade as well. And then we'll touch very briefly on what we hope will be the treatments of the future, both in clinical trials and just in standard clinical care. Because it doesn't, it's not something that we have to talk about very much, because unfortunately, although pediatric cancer diagnoses are true tragedies and devastating for every family and child that goes through them, unfortunately for pediatric brain cancer, we have a little bit higher of a burden in that our cure rates are not nearly the same as some of the other pediatric cancer diagnoses. Now, diffuse intrinsic pontine glioma is clearly a well-known and unfortunate diagnosis that we have a particularly bad track record in really coming up with good treatments for, but whilst some pediatric brain tumors have had some advances in their clinical cure rates, many have not. Nonetheless, it's not that we haven't been trying. So the Children's Oncology Group, as those in this room already are very familiar with, is the largest pediatric cancer organization in the world. And in the past decade to 15 years, they've been slogging through large clinical trials trying to figure out how do we make this treatment better. Our standard risk medulloblastoma protocol helped us to define that we can actually reduce the scope of our radiations without sacrificing cure rates. But perhaps most intriguingly, it was the first trial that really, from a perspective standpoint, has informed us that some of the biological insights that we've taken have finally helped us to tease apart which kids do well with this kind of diagnosis and which kid doesn't. It's been such a struggle for us. You find a child and a family that come to you, give them this diagnosis of medulloblastoma. The cure rates are quite good in standard risk medulloblastoma, but there are just those kids that should have survived or should have been cured and are not. And now we are understanding why that is. That translates over into our high-risk medulloblastoma trial, where we've learned that that phenotyping, or that understanding about which kid is which from a medulloblastoma diagnosis standpoint, really helps us understand where the treatment works or doesn't work. For instance, one of the major questions in this trial was whether addition of carboplatin to radiation, trying to augment our therapy, would actually be helpful. When you look at this well-designed trial as a whole, it wasn't helpful. But then by using the insights from this biology, what we realized is that actually it is very helpful for a very specific subset of children with medulloblastoma and not so helpful for the others. That's really the roadmap to how we hope to advance our diagnostic and therapeutic treatment in the future. Another component is, whilst we are always struggling with some of our more difficult to treat diagnoses or sub-diagnoses, intensification, really hitting hard with radiation and intensive chemotherapy, as was the case in this trial, did do a little bit better in these kinds of patients than other less intensive treatments, at least giving us hope that using our old tools of radiation and chemotherapy in a more intensive fashion may actually help us a little bit. Our ependymoma trial, this was a 15-year labor of love by Dr. Amy Smith, really started to answer one question, which is that whether chemotherapy is actually helpful in a child with ependymoma. The standard of care has for a long time been gross total resection and focal radiotherapy. But now we know that for some children, chemotherapy can actually increase their cure rates. And it's not always the case that we're going to advance, so sometimes you'll overshoot. And this trial was looking at nodular desmoplastic medulloblastoma, a particular subset of the medulloblastomas, thinking that these children did quite well, and we tried to reduce intensity because of the toxicity of chemotherapy, and we realized partway through that it wasn't working, and so that trial was stopped, giving us at least the insights to which we can give appropriate therapy to children in the future. High-grade trials where we have noted that certain biological insights have not yet translated into clinical findings. And then And then the trial that was looking at medulloblastoma salvage regimens and understanding that some of the tools that we already have can actually help us extend stability once tumor has recurred. So overall, what this really represents is a labor of hundreds of really, really smart scientists and doctors who have been using the tools that we had up to this point to try to use radiation and chemotherapy, and they have made advances, and they've formed the bedrock and the scaffolding that we're going to move forward for in the future. But the truth is, the real breakthrough over the last decade has not been in the clinic, but it has been in the bench. It's been in the laboratory. And what that's really done is by analyzing mutational burdens and by looking at RNA analysis, methylation profiling on the backbone of several large international groups. I'm just going to take a second to talk about methylation profiling. This is not DNA mutations. At the very beginning of my career, you think, mutations, that's the key to cancer diagnoses and cancer therapy and cancer susceptibility. But methylation profiling was really an attempt to analyze the epigenetic or the components of a tumor or a cell that are not directly related to the DNA, but how that DNA is read and translated. And using methylation profiling on the backbone of other sorts of diagnostic tools, we've really started to fine-tune which tumors are which. And then there are many other kinds of really interesting analytics tools like proteomics and single-cell sequencing, and you can keep going on. Really what this represents is the way that we can look at a cancer cell individually or in a tumor and distinguish it from other cancer cells and tumors that bear the same name otherwise. And that's important. I will take a moment, though, because when we think about, however, the problem of this two-edged sword, for ependymoma, for instance, we started that big 15-year trial and we said, okay, this is the problem. You have ependymoma tumors that arise in the top of the brain and the back of the brain and in your spine, and we're going to treat them all very similarly. And some of them are going to do okay and some of them are not. Now we realize on the backbone of many of these analytic tools that we just saw on the last slide that ependymoma is not a single disease. It bears a single name, but really it's 9 diseases at least. 9 diseases with different mutational drivers, 9 diseases with different molecular instigators, and thus it's not hard to take that next step to understand 9 diseases that are likely to respond very differently to particular kinds of treatments. What can we do with that information? Well, we can change treatments so that we can give the right treatment to the right patient. And that's true across the landscape of pediatric CNS tumors. We like to say that pediatric brain cancers are the most common solid tumor, but it's true also that unfortunately it's really a basket of diagnoses, and now that basket is becoming even more diversified. And ATRT, and of course we have to talk about medulloblastoma, which is really the kind of cancer that pioneered this gross analytical and fine-tuning of the diagnostic tree. So overall, what this tells us is, gosh, this is a great tool. Now we know maybe why some kids are cured by the treatments that we've been using and why some kids aren't. And now the next steps that we can take are to find out how to cure those kids who weren't cured. On the other hand, now instead of dealing on this slide with 3 diseases, now we're dealing with 15, 16, 17. So now I think that we're struggling with this idea of how do we actually investigate the next generation of treatments when we're perhaps going to be giving treatments only to each specific subgroup. And unfortunately, I think that it's not that we could ignore those components because the differences between these tumors, even within an overall umbrella diagnosis, they matter. And just as a few examples, it certainly matters because our histopathologists and our neuropathologists who've been so excellent in helping us define what a cancer is so that we know how to treat it, now have a whole nother set of tools that they can use to fine-tune even their old histopathological and sequencing methodologies. What that means, though, is that if it isn't done, that if the diagnosis isn't subjected to some of these next-gen techniques, in some situations, it's too difficult to really parse them out. And so by employing methylation profiling, RNA-seq, you can start to define a tumor's diagnosis a little bit more specifically. So what this is a graph of is there was a trial, that ACNS 0332 trial, that's that high-risk medulloblastoma trial. Part of that trial was actually designed to look at tumors that arose in the top of the brain and not the back of the brain where medulloblastoma normally lives. And what it noted is that despite the fact that there were some really expert doctors who were looking at these tumors and calling them this diagnosis, that when they employed these different kinds of techniques, they realized that this was really a couple of sets of tumors. It was the yellow line where you had sort of the tumor that was intended to be treated by this regimen, and those kids did not all survive, but they did okay. About 60% of them had cure rates. And then if you were actually what we call a high-grade glioma, and you were mistakenly diagnosed through no fault of of the doctors, but because of the tools that they were using at the time, then those patients were subjected to intensive radiation and chemotherapy, and they didn't survive. And so again, this is an example of where this fine-tuning of the diagnostic tree really helps us to give the right treatment to the right children. And that holds, that's true too when you're talking about a single tumor, ependymoma, in a single location in the back of the brain. Many of us know that that tumor has been divided into posterior fossa group A and group B tumors, and you can see that that actually makes a big difference when you subject them to the exact same treatment. So it's in the same place, it's the same kind of ependymoma tumor. This is not a different tumor type, and yet the molecular phenotype really defines how well you're going to respond to the treatments that we have. And then even if you drill down even further, so now we're talking about the same tumor, medulloblastoma, with the same molecular phenotype, the same molecular grouping, the sonic hedgehog-driven group. But if you have a single gene mutation or an alteration in a gene called P53, which we are unfortunately well too familiar with, you actually have a much worse outcome. And so the slide really talks about how these really fine-tuned diagnostic differences need to inform how we're designing the clinical trials of the future. But it's an opportunity as well. So I think that, it's hard to go about the last 5 to 7 years and not stumble across this great success that we've had with biological underpinnings and how to attack them. So low-grade gliomas are not tumors that are universally fatal. They're typically cured. However, if you look at this curve right on the right, you're really looking at the last largest low-grade glioma COG trial. This was looking at 2 different chemotherapeutic regimens. Both of those have a lot of clinic visits over 13 or 18 months. And while it looks like this curve isn't great, this is progression-free survival, most of these kids will go on to survive and be cured. But again, most of these children will actually recur. And what that recurrence means to those patients is that then they get radiation or they get additional chemotherapy. And once you recur once, you're very likely to recur again. So it becomes this sort of cycle of recurrence and treatment and cycle of recurrence and treatment again. Until we realized that some of these tumors were arising in these children who have a disease called neurofibromatosis. Neurofibromatosis, or NF1, is driven by a gene mutation in the neurofibromin gene, which is that NF1 space right there. And that led to insights that said, actually, a lot of these low-grade gliomas have aberrations in this pathway, this BRAF, MEK, ERK pathway. And then that led to the idea, well, what if we target that pathway? And so there were a couple of stops and starts when we did that. And then the PBDC-29 trial using selumetinib, which is a MEK inhibitor, really demonstrated for the first time that there were immense responses. So this is called a waterfall plot. It's just a way to represent the patients that were on this clinical trial. And the top and the bottom are just children with low-grade gliomas that had a mutation or a fusion in this pathway in the top, or children with neurofibromatosis, that first initial discovery cohort in the bottom, and look at these responses. So that first baseline is where they all started from a tumor burden standpoint. They start taking this oral medicine, which is very well tolerated, pretty limited toxicity, and many of these tumors responded. Now, the durability and the way to make sure that this is a response in all children, those are our next steps, but this was a major advance in the treatment of children with pediatric low-grade glioma and has now been translated into the largest first prospective trial in the children's oncology group testing this approach. And so what that really tells us, or what that really guides us towards, is how we are treating now and are going to be treating children with diagnoses in the future. So this is a great picture from Toronto's Sick Kids, and on the left-hand side is the old way that we used to look at gliomas, for instance. So you get this child and they have a glioma, and then the histopathologist or the pathologist, the neuropathologist says, well, this is either low-grade on the benigner side of the cancer landscape, or this is high-grade. And then for the low-grade tumors, if you either gave them radiation or surgery or chemotherapy as needed, and for the high-grade tumors, because their outcome was so poor, you actually just said, well, there's not a ton we can do, so we're going to give you radiation and we're going to aggressively try to take that tumor out, and then we're already going to enroll you on a clinical trial. That's our old landscape. It was a good paradigm to have, but it wasn't successful in most patients. On the right is our much more complicated, much more fine-tuned landscape, and this is what we're trying to do today, both clinically as well as in clinical trials. So when that same patient comes, their tumor is divided into low-grade and high-grade gliomas, but suddenly you have all of these specific molecular changes that can help you decide whether that tumor is, one, susceptible to a particular targeted approach that we already have or have in trial, or two, is a child that is going to require more or less treatment because they have either a high or low-grade tumor. As an example, you take a low-grade tumor, but that tumor looks very benign under the microscope using our old tools, has this mutation that's called this histone K27M mutation, which we know is a marker of very aggressive and resistant disease. And so suddenly that patient who might have gone on to just get low-grade glioma treatment now gets shunted immediately over into a much more intensive or investigational approach, affording that child and that family an opportunity to get cutting-edge treatment that will almost certainly be better, or hopefully better than they would have had before. Similarly, if you look at the high-grade tumors, if you have very specific mutations, we have already identified some very effective targeted interventions that can maybe reverse the trend for high-grade prognoses. And so it becomes now this tree that we walk down on the backbone of the science and the pathology and the molecular phenotyping to help us as clinicians to decide what better or more effective treatment is going to be. This is another representation from the same paper looking at ependymoma. Again, it divides up into sort of geographic region and then starts to look at that ependymoma tumor molecularly in the hopes that it was going to we'll come up with a better treatment that is more appropriate for each child. Well, you certainly don't have to look very far. You just have to look down at the rest of the agenda, which is virtually all immunotherapy. And the reason is, of course, because in the adult world, in many of these cancers that had no treatment, no cure, no effective therapy, immunotherapy sprang in and was hailed as the next savior for all those patients. And certainly we know that it's exciting to our community as well. This is Joanne Salcido. I've shown this slide before. It does need to be updated, but if you update those from the 2018, which is the last time this analysis was done, to today, that number is over 100, and that number represents pediatric brain tumor-specific immunotherapy trials. So the writing is sort of on the wall. Not only is it in the CCF agenda today, but it's also in clinical trials that are active currently. Just the breadth and number of people who think that immunotherapy is going to be our next step. And the reason is because we know the immune system can attack cancer. It does that in many different ways. We have a CAR T-cell talk in leukemia. That's been a very successful immunotherapy for standard B-risk B-cell leukemias. And the idea is fairly straightforward. You have a tumor, it gets killed by something, or it kills itself, or little pieces of itself, and the little pieces of its tumor then go out to the immune system, and much like an infection will then cause that immune system to raise up a T cell or effector cell response, which then goes and kills the cancer. The literature is littered not only with our clinical trials, but with also evidence that the immune system is quite effective at killing cancer sometimes. Unfortunately for brain tumors, there are a ton of different obstacles that we have to overcome at every step of this cycle, which seems so intuitive and seems easy and certainly helps us beat off the latest cold that we have. And so there's a lot of overcoming that needs to happen, and optimization and augmentation. However, there are a ton of different ways to kind of do that. And so there are different platforms of immunotherapy. It's not just one, and I suspect that what's going to happen is that for some kinds of cancers, some kinds of immunotherapy are effective, and probably all of them might even need combinations with each other or with other therapies as well, including vaccines, which we intuitively know about because we all have been getting vaccines. I think everybody in here has the COVID vaccine at least. Oncolytic virotherapy, antibodies, immune checkpoint inhibitors, which have achieved the notoriety of being one of our most successful in some kinds of cancer treatment interventions, and then adoptive cellular therapy like CAR T-cell therapy, which we'll hear more about today. So a lot of different ideas, a lot of different methodologies. The science is moving very quickly, and this is moving into the clinic as well as our next best hope. And the reason is because even though we say, gosh, pediatric brain tumors or brain tumors in general, immunotherapy has yet to really make a dent in them. There are true success stories. So this is a paper from several years ago now that was using an IV medicine called that immune checkpoint blockade. And what you see in the middle sort of column is a patient whose tumor has come back with a high-grade glioma. That tumor is essentially incurable with today's technology in general. And with this single agent, which does nothing else besides take the handcuffs off of the immune system, you see a complete response. It was really dramatic responses. This is an adult, young adult patient at Duke, and really the right way to look at this graph is sort of at the top ABC, the DEF, and with this oncolytic poliovirus, you actually see that their recurrent high-grade glioma, again, essentially incurable, did grow a little bit, maybe with the immune therapy coming in and becoming active, and then slowly shrinks down, and that panel F is more than 5 years post-treatment for a tumor that has been essentially incurable. It was certainly an amazing report. And while this patient didn't survive ultimately, this was an example of a CAR T-cell therapy really being helpful again in recurrent high-grade gliomas. And so where those arrows are, where all those tumors on the left-hand column were prior to therapy, prior to infusion with these CAR T-cells, and you have a complete response. This patient had disease all up and down his spine and his brain, and literally every single lesion disappeared with this CAR T cell therapy. Now, and it's a good example of how we still need to make advances because this tumor recurred and recurred robustly and in a spread fashion quite quickly for a lot of reasons that I think that we're going to be talking about later this afternoon. So we do have challenges. So we've talked about this promise and these great advances. These ideas of employing these diagnostic tools, not in the context of a clinical trial or in the lab, but in the context of the clinic and seeing a patient and a family, it's challenging because a lot of these things are brand new techniques and assays that haven't quite yet achieved the certification that we need, although some of them have as well. It takes a little time. So before the pathologist would take a look, would stain the tumor, might run a couple of simple tests and then tell you what it is. These tests can take weeks to come back, and those are weeks that often you don't easily have when you're trying to tell a family what's going to happen and plan for the treatment. And of course, as always, expense is a concern. However, we do still need to take these findings about how the prognosis can really be altered by these molecular phenotypes, these biological insights, and then validate them. And there are examples in our brain tumor community where we made some pretty big claims based on historical controls and biological insights. And then when we actually ran the prospective trials, we realized, oh, they actually weren't quite as robust as we thought they were. So this is the next step for the Children's Oncology Group, is really to start running the trials to verify and take advantage of these biological insights as well. But at the end of the day, this is what we really want. We want the next better treatments. So whether that's using targeted therapies in particular situations, or whether that's using immunotherapy, or whether it's using everything altogether, we have great hope that the science that has really evolved tremendously over the last decade is going to help us to evolve the clinical treatment in the next year. And the last thing I want to talk about is the way that we develop clinical trials. And I actually realize I have 0 minutes left on my timer. So I timed myself before this, and I was right under the 15 minutes. The old way, and the way that we develop clinical trials now, is really somebody has an idea at a single hospital, at a single lab, or a single company, and then somebody else writes that trial, and that trial is completed. And that trial probably fails. Most of these trials fail. Today, our community has changed the way that we're doing this. And we're changing it by saying, yes, those ideas occur, but we're actually going to have a lot of discussions before that trial is designed between the scientists and the biologists and the clinicians and the industry and the other foundation partners that can help us. And that's going to be sort of an organic, ongoing conversation. And while you're developing that clinical trial, you're also simultaneously deciding, how are we going to learn from this trial? Not only are we going to learn whether that trial worked or not, but if it didn't work, why didn't it work? If it did work, why did it work? So that way we can make that trial much better. The trial gets released. The correlates are a living entity that are constantly being fed back to the lab, and then that's coming back to design that trial so that we can continuously evolve those trials. This is a way that we are partnering biologists and scientists and preclinical, brilliant physicians and scientists with the clinical researchers who are running the trials. Ultimately, I wanted to thank you. Apologize for kicking us off in a delayed fashion. I know that those of you who know me know that that's my MO, unfortunately. But thank you again so much for having me both in person and to talk about this for a few minutes.